Good morning, everybody, and welcome to our webinar, What a Difference a Day Makes in Wound Healing Outcomes. And this is a new chapter in the Gecko device story. We've got a series of 4 speakers today. We are going to go through some new information, and we hope to give you some new tools for practice. But let's just say, as we're waiting for more people to join, that it is extremely important that we have standard of care for our patients with venous leg ulcers. This does not mean starting your actual compression therapy at the ankle. It should be at the base of the toes. You should go to at least 2 finger breadths below the knee. You really do have to have a good way of measuring vascular supply. You need to rule out infection. And then we look at the compression device, but you need to look at the patient as a whole as well. And, you know, we really, with wound bed prep, have said, look at the whole patient, not the hole in the patient. And so our first speaker today, and we have Christina Parker, second speaker, Holly Murray, third speaker, Kernan Day, and fourth speaker, Rochelle Duong. We're going to start with Christina. She is an associate professor at Queensland University of Technology in Australia. She has been a registered nurse for 28 years. She leads a research team at Queensland University of Technology. She's published 22 peer-reviewed articles, but the important one she's going to talk about is a venous leg ulcer tool. So let's sit back and have a listen to Christina.
Hello, my name is Christina Parker, and it's my absolute pleasure to be presenting today as part of the Perfuse-sponsored Wounds Canada session. I'm presenting as a part of a larger wound healing research team here at Queensland University of Technology in Brisbane, Australia. And we've specifically been looking at whether we can predict whether a venous leg ulcer will heal within 24 weeks, and the development of a risk assessment tool that we hope will be of use to clinicians, and to discuss our collaboration with Perfuse in relation to this risk assessment tool. So we know that chronic leg ulcers affect about 1 to 3% of the population. A chronic leg ulcer has been defined as a leg ulcer which occurs below the knee and does not heal within a 4 to 6 week period. And often it can take even months or even years to heal. We know that the prevalence of leg ulcers increases with age, and with an ageing population, this increasingly becomes a significant local, national, and international problem. Chronic leg ulcers account for 3% of the total health expenditure, which in Australia equates to $3.9 billion annually. Lower limb venous ulceration ranks as one of the 10 most common medical problems in Western countries. There's multiple etiologies for a leg ulcer. It could be venous, arterial, mixed with a bit of venous and arterial, diabetic or pressure in origin. But we know that about 70% of chronic leg ulcers are predominantly venous etiology. Venous leg ulcers usually result from incompetencies of the veins in the legs, often due to things like deep vein thrombosis or blood clots, or things like genetic weaknesses. And chronic wounds have a significant socioeconomic impact in relation to medical care, days off work, job loss in some cases, expenses for dressings, medications, transportation costs, and often result in a reduced quality of life. So I wanted to start with a short scenario. Mrs. F lives alone. She's 86 years old, and she has a leg ulcer on her left lateral malleolus, and she's had that for about 2 years. She originally knocked her leg on her wheelie walker that she uses for mobility, and it's subsequently never healed. This is commonly seen in the community and is a usual scenario in wound clinics on a daily basis all around the world. We know that community is often the first port of call for many of these people, especially when it's their first chronic wound. What we are unable to do objectively is to determine whether a venous leg ulcer will be difficult to heal. Evidence on healing times in the literature varies. However, overall, 70% of venous leg ulcers will be expected to heal within a 24-week period. This means that despite evidence-based care, 30% will remain unhealed. And it's important that we're able to identify those who will not respond to routine care early on in treatment to determine appropriate courses of action. At present, our healthcare practitioners utilise their clinical expert judgment and previous experience, with no real risk assessment tools being widely used to assist health practitioners to detect venous leg ulcers at risk of delayed healing or provide a pathway of care for people like Mrs. F. So we looked at the development of a risk assessment tool that could objectively do this for us. We used evidence from the literature, significant predictors of delayed healing from databases that we previously had collected data on at QUT, and we also utilised an expert wound advisory group to help determine whether to put together the risk assessment tool. The literature review identified a number of predictors, and these we classified as physiological, economic, social, and psychological. So in relation to physiological risk factors for delayed healing, there were things in the literature like lack of high compression, larger wound area, longer ulcer duration, venous abnormalities, mobility, recurrence, previous limb surgery, and age. When it came to the other categories, there were relatively few studies that concentrated on psychosocial or quality of life predictors in people with chronic venous leg ulcers and the risks associated with delayed healing. However, it is known that people with venous leg ulcers indicate profound effects of the ulceration on their everyday lives, feelings, and health-related quality of life. So things like low socioeconomic circumstances have been indicated in the literature, a lack of social support, anxiety, stress, and depression have been some of the risk factors that have been listed in the literature. And it was clear from the literature review that psychosocial factors should be examined further and definitely should be considered when developing a risk assessment tool. And this literature review has been published, and I've got the details on the screen, although a little old now, done in 2015. When we looked at a secondary analysis of databases that we had at QUT, this was a sample of 318 participants that had at least one venous leg ulcer, and they participated in prospective studies that we'd done between 2004 and 2011. And these participants had clinical, healing, health, and psychosocial data documented, and they'd been recruited from hospital and community settings. After adjustment for all variables in a generalised linear mix model, 4 factors remain significantly associated with delayed healing. Those that lived alone, a push score greater than 10, those that were not treated with high-level compression, and an ulcer area reduction of less than 25% within 2 weeks. And again, this work has been published, and I've got the details there. And this was the first study that actually acknowledged that people who live alone were significantly less likely to heal than those who lived with somebody else. A simple 10-item tool was put together with the wound expert advisory group that we had, and this included socioeconomic, demographic, venous history, mobility, ulcer and lower limb characteristics, and compression. And when totaled, higher scores indicated a higher risk of venous leg ulcer delayed healing or not healing by 24 weeks, and lower scores indicated there was a lower risk of the venous leg ulcer not being healed by 24 weeks. It was important that we looked at reliability of the tool, and I've got a picture here of Dr. Kathleen Finlayson, who led a lot of this work. And we had 3 raters that were assessed with 26 people with an open venous leg ulcer, and the inter-rater reliability analysis indicated statistically significant agreement for the delayed healing tool. Preliminary results on the inter-rater reliability have shown statistically significant agreement among all raters, with the total risk assessment score confirming good inter-rater reliability. The majority of the individual risk assessment items and subscales scored good inter-rater reliability results with an ICC of greater than 0.7. However, there were a couple of variables that were less reproducible and it warranted for further investigation. For example, the area reduction less than 25% at 2 weeks and the compression less than 30 millimetres of mercury were not as well done as the other variables. We then looked at the validation of the tool, and we started with a retrospective database. And the model had excellent discrimination and goodness of fit, with a significant area under the curve of the total score. Thus, the risk assessment tool correctly discriminated between ulcers that didn't heal and those that did heal 80% of the time. And that was for the total score. I've also included the scores for the baseline score and the 2-week score as well. We then looked at validation in a prospective database, and the results from the analysis of the risk assessment scores across 10 sites, which included community and hospital settings, showed that the model also had good discrimination and goodness of fit in predicting non-healing of venous leg ulcers at 24 weeks, and discriminated between ulcers that didn't heal as compared to those that did 75% of the time. This was slightly lower than the retrospective database, but was to be expected according to the literature. And I've got a picture of Emeritus Professor Helen Edwards, who led a lot of this work as well. And this work has also been published in the Diagnostic Accuracy of a Venous Leg Ulcer Risk Assessment Tool. So again, these results revealed that the risk assessment tool developed met the recommendations for a useful predictive score, providing a real-time prediction of the risk of non-healing by 24 weeks. We've also been able to validate this in an international population. So we've had sites across the UK, Austria, and also New Zealand. And this work is currently under review for publication. But again, we've been able to show that there was good discrimination and goodness of fit and good validation results with the model correctly discriminating between ulcers that didn't heal and those that did 74% of the time. So at present, there are no screening tools being utilised to assist clinicians to detect leg ulcers at risk of delayed healing in order to guide appropriate wound care management in wound care environments. The lack of such tools may contribute to the current high level of health service use for leg ulcers and poor rates of wound healing. This study has identified early predictors of delayed healing in venous leg ulcers that has further led to the development of a risk assessment tool. The identification of risk factors for delayed healing also offers an opportunity to determine realistic outcomes and can be linked to decisions in relation to alternative interventions when standard care may be insufficient to achieve healing. The identification of risk factors associated with delayed healing may also allow for modification of factors by appropriate intervention and thus influence healing. And there is also a need to review pathways of care for this population to ensure that best practice is being provided. So further study in this area has reduced the number of items in the risk assessment tool. So it's been reduced from 10 items to 8 items based on our further testing of the tool. This work hasn't currently been published as yet, but the risk assessment has been developed into an IT application, and this is available at the link on the screen. We've also looked at those pathways of care and evaluation of a care pathway for venous leg ulcers utilising the risk assessment tool as well. And when we tested this in a community setting, we found that 74% of health professionals found no difficulty in answering the questions. And for about 55% of health professionals, it only took them 1 to 3 minutes to complete the tool. What was also exciting was that the participants indicated that the people with venous leg ulcers were happy to be involved in the use of the tool, so real person-centred care, and that they would find the tool useful in their workplaces. So the risk assessment tool in Canada, and this has been a great collaboration that we've had with Perfuse. So it has been used in the continuing care clinical pathway for venous leg ulcers, but also after chart review was conducted within a home care organisation within Canada, there appeared to be a disconnect when identifying when adjunctive therapy, such as things like the Gecko, should be started for venous leg ulcer or people with venous leg ulcers. The barrier of accessing adjunctive therapy was removed by having the device or the Gecko available on the medical supplies and equipment formulary. But clinicians were only considering it for people who have been on service for 90 to 100 days. This home care service initiated a quality improvement initiative to determine if using a validated risk assessment tool would address the clinician gap between venous leg ulcer assessment and use of adjunctive therapy. Use of a validated risk assessment tool was used to stratify patients into 3 categories. So they were stratified into low risk, moderate, or high risk of not healing within 24 weeks, despite best practice. The use of this tool did help trigger clinicians as to when to consider adjunctive therapy. And with the use of the risk assessment tool, clinicians were better able to determine use of when to consider adjunctive therapy like Gecko, and the time to use went from 98 days to 54 days. The risk assessment tool has subsequently been implemented in this home care service. And we were very happy to provide permission and support and approval for the risk assessment tool to be used by Perfuse and within this research. So bringing it back to the people we care for, this risk assessment tool is evidence-based. It's easy to complete and can be applied cheaply in a variety of clinical and community settings to identify a cohort of people with venous leg ulcers at high risk of delayed healing by 24 weeks. A risk assessment tool could highlight the need to alter planned care, potentially avoiding weeks of inappropriate therapy and increasing quality of life for people like Mrs. F. So I'd like to say thank you again for having me speak. Of course, I would have loved to have been there in person, but that's not quite the world we live in at the moment. And from our wound healing research group at QUT, thank you for having us speak today.
Okay. I think Christina really has shown us a validated tool is very important. And if you saw the word RAT, just remember that did stand for Risk Assessment Tool. And patients that live alone are much less likely to heal. There's some evidence coming out in advances in December that actually patients with depression and patients with anxiety actually show delayed healing in venous leg ulcers as well. And when do we ever use in these patients a depression tool and anxiety tool, or really go into their social situation or the patient's circle of care? So I think this is a very important tool. And if you're not familiar with it, I would suggest that you have a look at Christina's tool. Our next speaker is Holly Murray. Holly graduated from Queen's University Bachelor of Nursing Science, Kingston, Ontario. Completed the Albany Medical Center Woundostomy Continence Education. She sits on several home and community care support services in her 25 years of service with Mississauga Halton. So I've had the privilege of working with Holly for a long period of time. and in 2009 got the Canadian Nursing Association certification. Holly's going to talk about how a change in practice in nurse-led wound clinic improves venous leg ulcer healing outcomes. Welcome, Holly, and you're on.
Good morning, everyone. I'm very excited today to share with you how a change in practice in our nurse-led wound clinic resulted in improved venous leg ulcer healing outcomes for our patients. Venous leg ulcers are a common reason for admission to the home care setting. These leg ulcers can be costly and can take many weeks to progress towards closure, impacting the lives of those that they affect. It was exciting for us to see that a simple change in practice resulted in both reduced costs and better quality of life for the patients we care for. Firstly, I'd like to start by sharing a little about Spectrum Healthcare, an organization I've been happy to work for the past 24 years. We have over 40 years of experience providing home healthcare services in the Greater Toronto Area. We're constantly evolving within the healthcare industry and actively seeking ways to provide innovative and quality care to our patients. The Gecko is just one example of this innovation. We provide both in-home and ambulatory clinic care to our patients with a mix of wonderful skilled RNs, RPNs, Canadian Nurses Association certified NSWOCs, and several staff who've completed the International Interprofessional Wound Care course. This combination of skilled staff helps us to offer the best practice care to our patients. Next slide, please. Venous leg ulcers have a big impact on the healthcare system and are commonly seen in both our in-home and clinic settings. Venous leg ulcers account for 60 to 80% of all cases of lower leg ulceration, and research has shown that 30% of these complex wounds remain open after a year of care. Unfortunately, up to 70% of them recur within a year of closure for a myriad of reasons, including patients wearing ill-fitting or worn-out compression garments, some choosing to stop wearing their garments or not wearing them at all after we close the wounds, and other related healthcare issues. At Spectrum Healthcare, we follow best practices for care with venous leg ulcers, including a lower leg assessment on admission with Doppler studies, wound assessments, and collaboration with doctors and vascular surgeons to help develop an appropriate plan of care. This care includes wound care based on ulcer presentation and compression therapy that is appropriately based for each individual patient's needs. In recent years, we've come to understand the importance of adjunctive therapies to help optimize the care for our patients with venous leg ulcers. We were fortunate to have the Mississauga Halton Lynn begin to provide the Gecko device in 2017 as part of the regular formulary. In addition to this adjunctive therapy device, it gave our clinicians another tool to consider when developing a plan of care for our patients with venous leg ulcers. Next slide, please. And if you could start the video, please. Thank you. The Gecko is an easy-to-use device that gently stimulates the common peroneal nerve, activating the lower leg muscle pump. In doing so, the Gecko increases the circulation equal to 60% of achieved by walking. Following a short hands-on session by our staff, the Gecko is simple enough for patients to independently manage. The patients are taught when to apply the device, how to turn it on, set it at the correct level of stimulation, and how to assess if it's in the correct location. They then apply the Gecko at home daily and return to our clinic at their predetermined intervals where they receive dressing changes and application of appropriate compression therapy. These clinic visits usually occur at intervals between 3 and 5 days. The patients wear the Gecko for 12 hours a day, 7 days a week, and they do remove it in between. Next slide, please. I work in the nurse-led Mississauga Halton Clinic, and now I'd like to share with you how a small change in our standard of care practice led to an improvement in our venous leg ulcer healing outcomes. Next slide, please. Initially, when the Mississauga Halton Lynn introduced the Gecko as part of our formulary, a patient with a venous leg ulcer was required to receive best practice wound care and compression therapy as a standard of care for a minimum of 30 days prior to becoming eligible to have the Gecko added to their treatment plan. Anecdotally, after we initially began to use the Gecko, both our staff and patients noted how much faster their venous leg ulcers were progressing towards closure when compared to good wound care and compression therapy alone in the first 30 days. We began to wonder what would happen if we didn't wait 30 days to use the Gecko. What if we began to use the Gecko as soon as possible following admission with our current standard of care? We decided to test these questions by evaluating 18 patients. These patients were started on the Gecko as soon as possible after admission, along with their usual standard of care. Wound measurements were taken at each visit to track the venous leg ulcer's progress towards closure. Linear advance of the wound margin was used to look at the differences achieved between our usual standard of care and the trial of standard of care plus Gecko. The following presentation by Kieron will discuss how using linear advance of the wound margin was used to highlight the outcomes we found in these 18 patients. Next slide, please. Prior to this evaluation, the average time to initiate the Gecko was 14.3 weeks, and the average time to venous leg ulcer closure was 15 weeks. What we found with the 18 patient case series was that by initiating the Gecko much earlier, on average by 3.8 weeks, we were able to achieve venous leg ulcer closure at just 6.7 weeks. This simple change in our practice resulted in an incredible 55% decrease in the time to venous leg ulcer closure. Next slide, please. Here's another view of what happened with our 18 patients. The blue bar on the side shows you the much faster healing that with the margin wound advance that occurred when the Gecko was added to standard of care versus the gray bar, which shows the standard of care alone. Here you can clearly see how much faster these wounds progressed. Next slide, please. The positive outcomes noted in this case series have influenced how we now manage our patients with venous leg ulcers. Patients are happy that we're able to discharge them to self-care with their own compression garments sooner. We have had few patients who did not close before their Gecko device was stopped. However, those patients did go on to heal. The residual effects of Gecko usage on increasing blood flow and quicker healing outcomes will require more study to determine if this does indeed occur. Patients in our clinic now have the Gecko introduced as part of their standard of care as soon as possible following admission and a lower leg assessment. This usually occurs in the first 2 weeks following admission. This improvement in our venous leg ulcer closure rate with the addition of Gecko is exciting, and I do look forward to seeing more research on this in the coming years. Finally, I would be remiss if I did not thank my fellow Spectrum Healthcare Mississauga-Halton Clinic colleagues. Although I'm the one presenting here today, they have all played a valuable part in every step of this series, and I thank them for their help. Thank you.
Okay, Holly, that was great presentation, and I think it looks at getting more evidence as possible in terms of the use of the Gecko with venous disease. Our next talk is by Kernan. Kernan is head of clinical affairs for Firstkind, and it's Firstkind and Perfuse that are really responsible for the Gecko in Canada. Kernan has specialized in or facilitating medical technology adaptation and therapy expansion. In the past, he worked for St. Jude Medical, where he was responsible for teams active in 30 countries in designing, management, and execution of clinical trials. And at Plaque Tech Limited in the past, he designed and managed a global medical affairs program. Kernan's going to talk to us about measuring progress to wound healing. And he is based in the UK, but he is with us today. Kernan.
Good afternoon, everybody, or should I say good morning? It's only afternoon for me, of course. Thank you for the introduction, Gary, and I'm very pleased to be here to present some of our ideas with regards to how we measure progress to wound healing. Next slide, please. Principally, my talk is divided into 3 segments. First, I just want to talk about how we currently measure wound healing. Then I'm going to propose a new, well, it's not a new method, but a addition to our current portfolio in the way that we measure those wounds and apply that to real world data. In fact, that data will be Holly's data that you've just seen. And then finally, I want to just speculate on how we could potentially use this information and incorporate it into a randomized controlled trial. Next slide, please. So, as we all know, wound healing is complex, and the whole point of this slide is relatively simple. The left-hand graph simply represents a predictive model for wound healing for 20 patients. However, the particular research then went into the field and went to recruit those 20 patients. And what they saw is represented in that right-hand graph. Now, there are many reasons why the healing of venous leg ulcers is so difficult to predict and complicated, but one of those reasons is that we tend to use 2 simple measures for assessing the progress to healing. The first of those is percentage area reduction, and the second is absolute area reduction. And as I'll show, well, as I hope to show, both of these can provide quite a skewed assessment of wound healing. Next slide, please. What we see here are 2 hypothetical wounds, A and B, on the left-hand side. These 2 wounds are exactly the same shape, and they both heal by exactly the same amount. In other words, what I mean by that is they both advance towards a hypothetical center of that wound by the same amount. Now, the first 2 columns on the table represent our 2 standard measures for wound healing. First, total area healed, and second, percentage area healed. So if you look at total area healed and compare A to B, you get a positive skew with it looks like that wound A, the larger wound, is healing 3 times faster than wound B. If you use percentage area reduction over time, then you get a skew in the opposite direction, where now wound B looks like it's healing twice as fast as wound A. What we're proposing is that we use a mechanism that was originally proposed by Gorin back in '96 and then expanded on by a guy called Vidal in the academic press around about 2017, where we take the area and the perimeter of the wound and divide the 2 by each other in order to try and remove that skew from our measurements. Indeed, if you look at the 3rd column on the table and you take the area and perimeter ratio and then look at the rates of healing, it now looks like wound A is healing at exactly the same rate as wound B. Next slide, please. I think this idea of how we can potentially skew our data sets with regards to how we look at them is an important concept. So the whole point of these 3 graphs is another way of comparing total area to percentage area to wound margin advance. When I say wound margin advance, I'm looking at the rate of area over perimeter. So for wounds, all these wounds are exactly the same size, all looked at over time and then plotted, the healing rates plotted over that time period. Again, if we look at total area healed, at the beginning of the trial, it looks like we get significant reduction of wounds over time. If we then reverse that and look at percentage area reduction at the beginning of the healing period, it looks like the wound is healing incredibly slowly. If we look at the ratio between the area of perimeter and then plot that over time, represented by our wound margin advance, it looks like we have a linear rate of healing. Now, if this is the case, and we can see this in real world patient populations, this also means that we may have the ability to give our patient population an accurate prediction as to when their wounds will heal. Next slide, please. As a continuance of looking at that area and perimeter, I just wanted to add one final complexity, if you like, and that is actually if you look at area and perimeter and that rate is linear, you can then begin to think about the slope of the curve or the line. Now, that slope of the line will give you a very exact rate of healing. So what we're looking at in this particular slide is two methods of measuring the same thing, and that is the rate of healing. Traditionally, we take measures on a week-by-week basis and then divide them by the number of weeks to work out with a mean healing rate. Now, that actually is quite an accurate way of doing it, but it does provide you with a high degree of variance. I'm proposing that actually if we look at the healing rate, then plot that over time, we can actually come out with a correlation. Again, it gives you a nice accurate rate for the healing projection, but you don't get the same degree of variance. So this indeed may be a more accurate way of looking at how our wounds heal. I just want to correct something I said 2 slides ago. I quoted Vidal as 2017. You can see from this slide, it's actually 2015. Next slide, please. So in conclusion, by looking at the area over perimeter over time, in other words, the wound margin advance of the wound, the rate at which the wound moves or heals towards the hypothetical center of the wound over time, as a measure to calculate the rate of healing, we get improved accuracy, we remove any skew or bias, and this is a genuine alternative to percentage area reduction or absolute area reduction as a method of determining how quickly our wounds are closing. Next slide, please. So the next logical step is to take this theory and apply it to the real world. And Holly was very kind in providing me with a small data set of 18 patients from the Mississauga Holton Spectrum Clinic, and I will now present that information here. Next slide. So onto that, initially, that predictability of healing. Holly's patients were actually monitored over quite a large period for some of them. Well, actually, the mean healing rate, I stand to be corrected, was about 6.5 to 7 weeks for patients who are using the Gecko device in conjunction with standard of care. I've simply looked at the first 4 weeks as a snapshot in order to predict how quickly our wounds are healing. And I've plotted the wound margin advance, area over perimeter over that 4-week period. And I hope that you will agree that during this time frame, that the wounds are healing and appear to be healing in a linear fashion, and that enables us to potentially look at these wounds and predict that when these wounds will heal. Next slide, please. And additionally, as you can see, we can now compare different methods of wound healing. So on the left-hand side of this graph, we see standard of care alone, compression bandage therapy. And on the right-hand side, we see compression bandaging in association with the Gecko. And as previously shown during this presentation, we see a 55% increase in the rate of healing with when you utilize the Gecko device with the standard of care, it healing over twice as fast as when you look at standard of care alone. Next slide, please. So how can we apply this in the real world and hopefully use this as a reasonable tool within a randomized controlled trial? Next slide. Thank you. So if we have a way of measuring wound closure that is proven to be linear, we can therefore compare the rate of healing when you have a standard of care patient to the alternate method of care. In this case, it's standard of care using the Gecko device as a conjunct to that therapy. So the idea being with any possible randomized controlled trial is that the patient will become their own control, and you can do pairwise comparisons. So you can calculate a patient's rate of healing before the Gecko device is applied over, let's say, a 4-week period to their rate of healing after you've applied the Gecko device. And this is exactly what you can see in this slide here, and it is indeed a working hypothesis for a trial that we would like to complete here in Canada in the near future. Thank you.
Okay, thank you, Kernan. And we are now moving on to Rochelle Duong. She is the National Director of Clinical and Market Development for Perfuse Medical. Rochelle is a registered nurse. She has worked in industry, working with global manufacturers and distributors of wound healing and medical device space. She has, however, led and been Holly and my colleague in Mississauga-Halton, where she really led regional practices in wound care solutions. So I think it's very important that Rochelle has been on both sides of the spectrum. Rochelle?
Thank you, Dr. Sibbald. So we always often get asked the question, how much does the device cost? So while I was working at Mississauga-Halton, we often got asked that question as well when we looked at innovative therapies and adjunctive therapies. So what was done in my time at Mississauga-Halton was we compared the direct nursing cost, our costs of dressing supplies, the cost of the device, as well as the length of healing for those provided with Gecko and standard of care, and for those that were only provided with standard of care. During this time, when we compared by patient, because of the accelerated healing that we saw with Gecko, there was an actual cost avoidance or cost savings of $6,200 per patient. In the acute care setting, there have been studies done as well through randomized controlled trials. And because of the success that Gecko provided in reducing post-op complications, cost avoidance within the acute care setting was $2,300 per patient. If you'd like to learn more about what your potential cost savings will be within your environment, feel free to visit us at the Perfuse MedTech booth today or contact your local rep. Thanks so much.
We now have time, about 15 minutes for questions. Now, some of your questions have been answered directly in the chat. Other questions will go to the various speakers, and there's some really very interesting ones. The first one I'll comment on, and this is from our VAS. You can't really use a tool validated for venous ulcers for arterial or mixed ulcers. I think that that's a mistake, and it's like people using the pressure injury classification system of the 1 to 4 classification of stages and applying it to venous ulcers or diabetic foot ulcers. And these are all disease-specific tools. Holly, do you want to make a comment on that?
I'm sorry, I was actually reading some questions.
Okay, no problem. That's fine. This is just using tools designed for venous ulcers, for arterial ulcers or mixed ulcers.
That gets tricky because although we're talking about lower leg ulcers, they're all slightly different beasts. So I try to personally stick to using a tool that's being validated for a particular kind of lower leg ulcer.
Yeah. Now, the venous ulcer tool, though, can be used if you're talking about mixed arterial and venous, or mixed venous and arterial, and always put the name of the primary ulcer first. Then you could use the tool, and the patient would most likely fall into a non-healing category, because that tool, very interestingly enough, even if you're using moderate compression, you're not using high compression, that gives 3 points against the ulcer healing. So I think that what you're looking at is, a low probability of healing. Now, I like this question a lot, and this is from Allison. Most patients do not tolerate compression over 20 millimeters of mercury. So are there any strategies to improve their tolerance for compression? Well, the very first thing I'm going to tell you is you got to look at pain control. And you have to know what their Doppler studies are. And what we've done in the community now is we've used the audible handheld Doppler. So a nurse can go into the home, can use the Doppler device on the foot, even with the patient seated. They don't have to lie down. You don't have to compress their lower calf until the signal goes away. You don't have to wait 20 minutes. It's not painful. And the result is not influenced by calcification. And we actually validated that in 2015 with Dieter Meyer, who I believe is actually talking at this meeting. But Dieter had us go through 200 of our patients, and in this validation published in Vascular. And if you hear a shh, shh, then that patient needs full vascular studies, or if you can't get a Doppler. But if you can hear bishu, 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 or you hear bishu, bishu, so that you hear a double sound, and you can actually record that on your phone. And Andrew, that's an MP3. And so that if you record that on your phone, you can have that available for external validation. And in our patient navigation study with Waterloo Wellington, we're doing this. And if you've got a biphasic or triphasic wave, you've got a 98% chance with the dorsalis pedis and I believe 97 with the posterior tibial or vice versa, that you have enough blood supply to heal and you can use high compression. So you can do it in the home, and you can have, you can actually have a record that's reproducible to show that. But always look at the patient. Don't rely on a single test. You know, if they've got dependent rubor, if the foot is cold, you know, if they've got pain with the leg up, then you've got to look and, you know, there's something wrong. But I certainly think that's the first thing. The second thing is to check and treat their pain. We have inadequate pain management for most of our patients. And if that pain is gnawing, aching, tender, throbbing like a toothache, then acetaminophen, because in people over 65, you want to avoid non-steroidals. And we're now using a little bit lower doses, usually 2 grams or 2.5 grams. And acetaminophen, for people living in Ontario, it's on the drug benefit, 1 gram at breakfast, 1 gram at supper, and 500 milligrams at lunch. But you have to know their renal and their kidney function. And then you move on to narcotics, etc. If it is burning, stinging, shooting, stabbing, that's neuropathic pain. And there are really good Canadian guidelines where we start with the gabapentinoids, gabapentin or Lyrica. Gabapentin, you can go up to 3,600. Lyrica, you can go up to 600. You have to start low and go slow, or they get confused. And the second agents in are tricyclics. And the second generation ones like nortriptyline 10 to 30 at night. Third generations are antidepressants, but also third generations now are CBD oil, are CBD gummies. So CBD is very good for neuropathic, but not nociceptive pain. So control the pain. And the other thing, and I'm going to come back to Holly and Rochelle to add to this, but the other things that you can think of is starting with something like edema-wear, Tubigrip, Elastigrip, you know, with a single layer type of device. If it's an irregular leg, edema-wear might help. And then you move up to light compression, whether it's the Coban 2 light or you use an zinc oxide paste boot. There aren't so many people using 4-layer now. And when I order it, it's often put on incorrectly, so that, and often too tight, and we don't have enough consistency of care. And then you can move up to the full compression. Go slow, work with your patient, get pain control. And of course, what if you've missed infection? And we use NERDS and Stoney's criteria. NERDS we treat topically 3 out of 5. Stoney's 3 out of 7 we treat systemically. And I think that, you know, there are other reasons for pain that need to be addressed. Rochelle, do you want to add to that at all? What do you think?
Yeah, actually, I'd like to turn it over to Holly to share some of her direct care experience within Mississauga-Halton.
Okay, Holly, help us.
So I completely agree with you. We often use sort of the stepstone of increasing the stair method of increasing the compression, starting off with something. If we've got good ABIs, especially in someone that's elderly, if we throw them right into high compression, it becomes a no-go. So we will often start off with a Medi grip or 2B grip, or like you said, the edema wear, or a moderate compression, so something like Coban 2 Light, and then over a couple of weeks, move them up to high compression. Specifically with the Gecko, we found in using that, because it reduces edema and improves the microcirculation, it helps to reduce the pain when it reduces some of the edema. So we found that to be an effective adjunctive therapy to assist with the pain management in conjunction with medication and everything else as well. But it's also been a very effective way to help manage the pain by reducing the edema. And then we get the patient's more agreeable with the high compression as well.
Okay, Rochelle, what are the contraindications to Gecko? And Jolene is asking this.
Sure, there aren't really any contraindications, but we do pose a few warnings where you might want to consider consulting the physician, or just making sure that they're aware that you're starting Gecko, and that's for pregnancy, as well as if they've got a pacemaker, or if they've got newly diagnosed DVT within the last 6 weeks.
Okay, and just continuing on that theme, and I think maybe it's Kieron. What about studies in acute care? And I know there are some studies ongoing that might, has anything been published yet, or are you in the actual study phase?
So for the venous leg ulcers, it's pretty much all in the study phase. However, for arterial and mixed etiology ulcers, we have a couple of papers published in the last few years, specifically D.Sc 2020 and 2021, which will give you an overview of how the Gecko affects microvascularization, increased flux in the wound bed, and also increased blood turnover in the wound bed as well. Diabetics next on the list. We've got nothing planned for pressure ulcers at this time.
Okay, and we have a question. How are you calculating the perimeter if you have an irregular wound edge?
So we currently use Arant's Silhouette software, which is a specialized camera that automatically has been validated by the FDA, measures the area, depth, and perimeter of the wound. For our next study and studies that we hope to complete here in Canada, we'll be transitioning to an organization called Tissue Analytics. But the simple answer is, it's a computed automated process from a validated imaging system.
Okay, good. And I think you don't see me very often in front of commercial presentations. And one of the reasons I'm here is because Firstkind and Perfuse have really agreed to do a random controlled trial in Ontario. And this random controlled trial will look at standard of practice and high compression for 4 weeks. The patients will then be randomized to either get the Gecko device plus standard of care, or standard of care for 4 weeks, and then be followed for 12 weeks out. So that, you know, we've got a 20-week study. And this should really show, and this will complement or be able to be used in meta-analyses to look at a European study that did the similar things. But we've actually put in the audible handheld Doppler. We've put in the high compression necessity. We put in grades of venous disease, and we put in the NERDs and stonies for infection. So we think we've got a very high scientific standard, and something that is really going to show us what the Gecko is going to do. And there are 5 or 6 centers in Ontario, and we're just finalizing this to do it. And I think being able to use this study to improve, as I mentioned at the beginning, venous ulcer therapy becomes an extremely important issue. So I think we can improve compression, pain control, treatment of infection. And partly we're doing this with the University of Toronto and Queen's University, and an advanced certificate of completion with the IIWCC, traditionally ECHO, to learn how to work in an interprofessional team. Because, you know, 20% of clients make up 80% of the cost in home care. And if we can get better treatment for these clients, we can save money. One of the posters at this meeting with Jane, Hyde, and Helen from Waterloo, Wellington, is patient navigation, is actually getting patients off home care that have been on home care for 10 years. And we're working as an interprofessional team right within the system rather than outside the system and with the service provider agency. And the other thing we need to advocate is for better pay for nurses in home care so that they don't leave and they're recognized as being very, very important. I see that there's another answer here on currently piloting Gecko for lymphedema. I think that'll be interesting. You really need to grade the lymphedema so we know if it's woody or if it's still changed. And I think that that is important. And whether it's available in Nova Scotia or various regions, I'm suggesting that you go to the Perfuse booth. We can answer general questions at the Woundpedia booth, but that would be a question that would directly need to go to the booth. And the funding is very different in different places. And Rochelle, do you want to comment on the funding? It's a variety of things, and they're also asking about who can order it. You know, and you came up with an interesting answer for me earlier on, so go ahead.
Sure. So right now it is available across 8 of the home and community care groups, whether it's on their formulary or assessed by an NSWOC. So have a look to see what's available within your home and community care. In terms of an order, so again, that will vary in various organizations. You don't need necessarily a physician's order. A clinician can order. In fact, patients can purchase directly through Perfuse if they want to consider private pay. But in Mississauga-Halton, I'll turn that over to Holly so you could share what it's like in Mississauga-Halton in terms of accessing Gecko.
So in Mississauga-Halton, there was a group of clinicians that came together with the LIN, and we developed a tool to ensure that appropriate lower leg assessment was completed, that the person was moved into compression therapy for VLUs, and we were documenting the size of the wound. So this form is filled out by an NSWOC or physician. It's submitted to the LIN, and that initiates the Gecko device. It's sent out 2 weeks at a time, and then reassessed at 2-week intervals to ensure that we are seeing improvements, and the patient can receive up to 8 weeks of therapy covered by the LIN. So it's a form that we use, a tool that was created collaboratively that we use to initiate the device in this area.
Okay, we are just about at the end of the line. I would certainly use Gecko with pentoxifylline. It has proven efficacy, especially in venous ulcers over a year. Infection isn't a contraindication, but you have to treat the infection, and I think that that is very important. If you want to hear the sounds again, and you go to the Woundpedia site, first of all, the Woundpedia site, or you can go to our booth, and Dieter Meyer's video is up demonstrating this, or we can demonstrate the sounds to you again. So I think as we're going forward, thank you, Kieron, thank you, Holly, thank you, Rochelle, and our thanks to Christina. Well, thank you, everybody. I think a lot of information. Follow up, look at the new Wound Bed Prep 2021. It's free to download, and you know what? We can do better, and we can make home care better at a lower cost with increased nursing salaries. Thank you.
Thank you. Goodbye.